repeat, but for the rest of the group, on August 24th, a 76-year-old male presented to the emergency department due to coughing out his teeth voice prosthesis. He had a history of a total laryngectomy and esophageal puncture with a voice prosthesis. The ED documentation on discharge indicates that the patient was sent home with an insertion of a catheter in his device. He was also not evaluated to see that the prosthesis was coughed into the airway. The patient was told to return to the ENT clinic the following day. On August 25th, the patient was seen by speech and ENT services. The patient was scoped by ENT and the prosthesis was found in the left main branch of his airway. The patient then needed a pulmonology consult to remove the prosthesis. The patient was not in distress, but should have had a catheter inserted into the puncture site to maintain patency and reduce the risk for aspiration. The patient should have also been evaluated to determine if the prosthesis was coughed into the airway. The intervention is to insert a red rubber catheter into the device once the prosthesis is removed from the airway until a new voice prosthesis can be inserted. As a result, the patient safety manager conducted a meeting with speech, ENT, ED department, and respiratory therapy. There are approximately 10 total laryngectomy patients in Albany, and not all of them have one of these devices for speech. This is a high-risk, low-volume process. Speech therapy developed education for the ED and respiratory therapy staff on the proper management of patients with a total laryngectomy and the teeth voice prosthesis. So alignment to HRO is sensitivity to operations, focus on frontline staff and care processes, and preoccupation with failure, anticipate risk, and every staff member is a problem solver.